babies are born in the same city, same country, same hour, one will live 20 years longer than the other. Not because of genetics, not because of luck, because of money. This is not a metaphor. This is the documented, measurable, preventable reality of healthcare in 2025. Day 14 of my journey as a global health and wealth architect, and today we go somewhere that makes powerful people deeply uncomfortable. We talk about who dies early, and exactly why. The brutal geography of early death. Your postcode, where you were born, where you live, what your neighborhood earns, is one of the strongest predictors of how long you will live. Stronger than your genetics, stronger than your personal choices, stronger than almost anything your individual willpower can overcome. In Brazil, a child born in a wealthy neighborhood of Sao Paulo can expect to outlive a child born in a poor municipality of the Northeast by up to 25 years. 25 years, same country, same flag, different destiny, written at birth by economic geography. In sub-Saharan Africa, the gap between health outcomes in wealthy urban centers and rural or impoverished communities is equally stark. Maternal mortality rates in the poorest communities can be 10 to 20 times higher than in wealthier areas of the same country. Children under 5 in the poorest quintile die at rates that the wealthiest quintile have not experienced in decades. This is not fate, this is policy, and policy can be changed. Why the wealth gap kills, the mechanisms. Let me break down exactly how economic inequality translates into early death. Because it is not simply that poor people cannot afford medicine. The pathway is far more structural than that. Food and nutrition. Chronic poverty means chronic nutritional deficiency. Stunted children become adults with compromised immune systems, reduced cognitive capacity, and elevated chronic disease risk. Hunger is not just a social problem, it is a public health catastrophe in slow motion. Housing and environment. Poor communities live in environments that make them sick. Overcrowded housing spreads respiratory disease. Lack of clean water drives infectious disease. Poor sanitation kills children. Environmental pollution, disproportionately located near poor communities, elevates cancer and respiratory disease rates. Healthcare access. When you are poor, the clinic is far away. The transport costs money you do not have. The consultation costs money you do not have. The medication costs money you do not have. So you wait until what was manageable becomes an emergency. Until what was treatable becomes terminal. This is not personal failure. This is system design. Chronic stress. The science of poverty is clear. Living in chronic financial insecurity elevates cortisol, the stress hormone, at levels that damage the cardiovascular system, suppress immune function, and accelerate biological aging. Poverty is not just an economic condition. It is a physiological one. What a health and wealth architect sees. This is where my work as a global health and wealth architect comes into full focus. Because I refuse to separate the conversation about health from the conversation about wealth. They are not two subjects. They are one system, and the architecture of that system, who has access to resources, who lives near pollution, who can afford a doctor, who gets a mortgage and who gets a slum, that architecture determines who lives and who dies more reliably than almost any clinical factor we study in medical school. So what does the solution look like? Direct primary care for underserved communities. A DPC practice embedded in a low-income community changes the healthcare equation for every family in its reach. Affordable membership. A doctor who knows your name. Preventive care that catches the chronic disease before it becomes the emergency. Community wealth building as a health intervention. Microfinance programs, cooperative economics, community land trusts. These are not just economic tools. They are public health tools. Every family lifted out of chronic poverty is a family whose health trajectory changes permanently. Faith community partnerships. The church and the mosque in underserved communities are already there. Already trusted, already embedded. Partnering them with primary care creates a health delivery network that no government program alone has ever been able to build. Policy advocacy. Healthcare financing reform. Universal primary care coverage. Progressive health taxation. Pharmaceutical price regulation. These are not radical ideas. They are the policies that every high-income country with good health outcomes has already implemented. A direct word to young leaders. If you are a young person watching this, and you are building a career, building wealth, building a business, I want you to understand something fundamental. The wealth you build is not separate from the health of your community. Every business that employs people and pays them a living wage is a public health intervention. Every investment in a neighborhood that creates safe housing is a public health intervention. Every mentorship of a young person from a poor community into a professional career is a public health intervention. Wealth, deployed with intention, with faith, with vision, is one of the most powerful health tools available. This is why I refuse to separate my work in global health from my work as a wealth architect, because the communities I am called to serve need both a doctor and an economist, both a clinician and a builder, both someone who can treat the disease and someone who can redesign the conditions that produced it. That is the global health and wealth architect. That is this journey, and that is why Day 14 sounds less like medicine and more like a manifesto. If this stirred something in you, share it with one person who needs to connect the dots between wealth and health. Subscribe, comment below. In your community, how visible is the gap between rich and poor health?